Thank you. Well, the first thing I'll point out is on my first slide that we mislabeled the name of my laboratory. It's the Advanced Pulmonary Physiomic Imaging Lab, which gives you Apple. I'm going to talk mostly about CT, but there will be a little bit about some developments in magnetic resonance imaging. I got my start in a laboratory at the Mayo Clinic in the mid-1970s, where we developed, at the same time that Hounsfield was developing CT in the basement of Emmy to image a single slice of the dead brain, we were trying to image the three-dimensional beating heart and breathing lung. And so the lesson there goes simple, that Hounsfield won the Nobel Prize while we were still trying to image the beating heart and breathing lung. But it was a machine that had 14 X-ray guns in semicircle aimed at a hemi-cylindrical fluorescent screen, looked at by a bank of television cameras, and then this 20 tons spun at 15 RPM and was able to extract images of the lung. And what we saw was that the mathematics works out such that the Hounsfield units, or back then it was before there was such a thing as Hounsfield units, the reconstructed attenuation coefficients are linear between air and water, and the lung, fortuitously, really is only air or water. So if you know what air and water measurements are, voxel by voxel, you can get a map of percent air and percent water. And much of what we want to know about the lung is really told in that measurement. Air trapping at full expiration is too much air. Emphysema at full inspiration is too much air relative to water, so it gives us a signal, and that's taken off over the years to give us some of the measurements that I'll show you. The first thing, though, is that a typical lung scan that you'll get at the VA hospital, in the radiology department at the University of Iowa, will not really give you these needed quantitative measurements, because full inspiration, the technologist's instruction of the patient is, okay, try to take a deep breath in now and hold it. That in a pulmonary function laboratory, you'll hear the technician screaming at the patient, breathe in, more, 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 you can do it. And that's what you need to do in the CT lab. And so you need coached total lung capacity. A number of older studies have used functional residual capacity for the expiratory volume, but in a pulmonary function lab, you don't really measure air trapping at FRC. You measure it at residual volume, and that's where you really need to be. FRC was chosen just for convenience in the older days, when it took a 40-second breath hold to get the volume of the lung, and nobody could hold their breath at RV for 40 seconds. But now it takes under a second to gather 600 slices of the lung. You want a standardized kilovoltage and a CT dose index per volume, standardized scanner-specific reconstruction kernels, standardized slice thickness and spacing, and that for multiple vendors, we've identified scan protocols that yield fairly similar measurements, and that was part of a multi-center study sponsored by the NIH known as Spiromics, and the paper is marked down here. So if you do measure the lung at coach TLC and residual volume, you can then pull out, the computer can automatically pull out the right lung, the left lung, the lobes, the airway tree, the vascular bed. If you have the airway tree, you can find the center lines. That gives you the branch points. So then that gives you the airway segments, and then the computer can be trained to automatically label these airway segments. And then empirically, it's been found that voxels, the TLC, that are below minus 950 Hounsfield units are emphysema-like, and voxels below minus 856 at RV are air trapping-like. I say like, it's not necessarily emphysema. If your voxel is in the middle of an airway, you'll have 100% air, and it's not emphysema. So there's a certain amount of normal number of voxels that you'll find that are emphysema-like, and those are dependent on sex, ethnicity, or not ethnicity, but race, and so there's a set of normative equations that have been developed to define where the threshold is for saying that somebody has emphysema or not. And then there's a whole lot of measurements that can pour out of this. You can do image matching from the inspiratory to the expiratory image to give regional mechanics, Jacobians, anisotropic deformation index. There's the texture of the grayscale that can, the computer can be trained to recognize different tissue types. And I'll describe all of these as I go on through the talk, but as it turns out, we can get over 200 to 300 measurements per lung scan to characterize the lung. Just to show you that if you do everything very carefully controlled, that here's a study where we used coached expiration of residual volume in a set of patients that had cystic fibrosis, and they had a particular CFTR mutation, and that there's a drug, Ivacaftor, that was developed that can restore function in this mutation. And you can see that in 2 days we were able to show significant improvement in the lung, which visually you would have never been able to do this. Texture measures, there's ground glass, honeycombing, reticular, bronchovascular, emphysema-like, etc. And you can train the computer. If you get a set of radiologists to agree what type of texture regionally you have, you can then train with a Bayesian classifier the computer to find those textures. In order to train the computer, we needed 4 or 5 radiologists and a vote as to what texture it is, because none of them can agree with each other or themselves. But in this study, ground glass reticular, the burden of ground glass reticular at baseline in patients with IPF will predict the likelihood of the rapid progression of IPF, which is important in terms of deciding what drug and how much drug to give for treatment. A colleague of ours in the Hydraulics Institute at the University of Iowa, Chin-Long Lin, and his graduate students have used our images to establish a set of geometric metrics of the airway tree, branch angles, wall thickness, center lines, hydraulic diameters, structural relationships in the lung, regional Jacobians that tell you the warping of the lung when you match TLC to RV, the anisotropic deformation index, how uniform or non-uniform does each region of lung change. And using that, he's been able, using data from the Severe Asthma Research Program funded by the NIH multi-center study, looking at trying to find out what's the difference between a severe asthmatic and a non-severe asthmatic. That using only imaging metrics, he's been able to identify 4 clusters that turn out 2 of them represent patients that are non-severe asthmatics and 2 are severe asthmatics. and that if you then take these independently identified clusters and look at the clinical characteristics, there are very important distinct differences, including prevalence of neutrophilic dominant inflammation versus eosinophilic dominant inflammation and so forth. And then he's taken example patients from each cluster and applied computational fluid dynamics to estimate how various particulate matter would flow through the airway tree, and identified two clusters where there's significant reduction in the delivery of particulate matter to the periphery, and that results in accumulation of that particulate matter in local regions of the airway tree. Now, in some instances, it's bad for the person to accumulate, say, an environmental exposure particulate into that region of the airway tree, and that might yield some new insights. In other cases, you're trying to get a drug to the peripheral air spaces, and if you're one of these clusters, you may have trouble getting your inhaled drug out to the lung periphery. Ben Smith and Graham Barr at Columbia University, together with us, and as part of the MESA lung study and the Spiromics study, both sponsored by NIH, and both large multi-center studies, and we're the radiology center for these. He's used the fact that we have each airway segment labeled through the airway tree. So he compared segment for segment subjects with COPD and subjects without COPD, and showed that consistently and surprisingly, people with COPD have thinner airway walls than people without COPD. Typically, we think of people having thicker airway walls, but it's that you aren't comparing segment for segment, the exact same segments. And it's not to say that nobody with COPD has thickened airways, and in fact, airways can appear thickened because of mucus accumulation as well. But just in general, there are thinner airway walls in people with COPD. This goes along with some data with micro-CT that has come out of Jim Hogg's lab in Vancouver, where he's shown we've developed methods. Dragos Vasilescu, who is a graduate student in my lab now working with Jim Hogg, has developed some micro-CT techniques that allow us on excised fixed lungs to image at 1 to 2 micron resolution and characterize the structure of the acinus. Using some of these techniques out of Hogg's lab, they've shown that people with central lobular emphysema look like they have thicker airway walls at the pre-terminal bronchial regions, but because they have volumetric imaging, they can measure the total volume of that wall of that pre-terminal segment, and have shown that in fact it's decreased in volume even though there's this appearance. And what Jim has also shown is the fact that the earliest process of emphysema is loss of these terminal airway walls, not the destruction of the alveoli. The destruction of the alveoli followed the loss of these terminal air segments. Out of Ann Arbor, Galban and colleagues have developed what's become known as the parametric response map, taking an inspiratory image, matching it to an expiratory image, and then adjusting the air trapping measurement to eliminate any voxel that's emphysema-like, eliminate that from the voxel that's air trapped, so that you get a pure air-trapped assessment with the idea that the initiating event is functional small airways disease, and that leads to emphysema. So by eliminating the emphysema from the air trapping measurement, they can then follow that hypothesis. And there's been quite a bit of recent publications of that. But they still use, to define emphysema-like voxels on inspiration, air trapping-like voxels on expiration, they still use this simple standard threshold of -856 or -950. And depending on the inspiratory or expiratory effort, depending on the particular scanner, that can change a bit where that exact measurement is. So that's a bit of a weakness of this method. So there has been a new method very similar using inspiratory and expiratory matching, but avoiding using simple thresholds to define emphysema and gas trapping, but actually using the change in regional Hounsfield units, using the change in Jacobians, sort of the volume change, the anisotropy of that volume change, etc., to create a probability map of whether a voxel is emphysema-like or gas-trapped. And also, they, in this measurement, provide whether the emphysema is trapped or emptying. And that changes the relationship of this emphysema measurement to pulmonary function tests. Looking more centrally at the airway tree, again, Ben Smith, Graham Barr, together with us as part of Mesa Lung and Spiromics again. Ben Smith did a heroic job of looking at thousands of CT scans visually and identified two common variants to the most common branching pattern in the lower lobes, and identified an absent right medial basal segment in 6% of the overall population and 16% of an accessory subsuperior segment in 16% of the population, and showed that in the COPD population you have an enhanced prevalence of these two common variants of the airway tree. And that if you have one of these common variants of the airway tree, your likelihood of getting COPD is increased even if you don't smoke. And then he showed we don't think that just having that one little segment of the airway tree present or missing is going to cause you to get COPD, but that we think it's a fingerprint of the whole lung being different. And that in fact in this absent right medial basal variant, he's shown that segment for segment, the segments are considerably smaller diameter, small in lumen area, than the same segments in people with the more common branching pattern. And in the other branching pattern, the segments are shorter, meaning that to get out to the periphery, you have up to 6 extra generations of the airway tree. To get more at functional measurements with CT, we developed some methods of using stable xenon gas, which is radiodense, and looking at wash-in and wash-out during a breath hold, looking at wash-in, wash-out at the same point of a respiratory cycle, scanned at the same point of the cardiac cycle, and these are in animals. We would never have scanned a person this many times. But you can see the wash-in, equilibration, wash-out, and that provides that time constant locally for the wash-in or the washout gives an index of regional ventilation in mLs per minute. Using that in smokers, we showed that there's a significant patchy presence of low or no ventilation in smokers compared to non-smokers. And then for blood flow, again with a breath hold gated to the imaging gated to the cardiac cycle, we injected a sharp bolus of iodine into the lung, and then looked at the first pass kinetics and comparing those time intensity curves out in the parenchyma to the time intensity, the input function in the pulmonary artery, we can get a measure of true perfused blood volume. Using that in just an experiment that happened to be going on looking at washout of surfactant, Brett Simon and colleagues came from Hopkins and used our lab to look at sheep where they washed out the lung with either saline or endotoxin. And we found that if you wash the lung out with saline, you then are left with a region of dependent lung that's almost certainly hypoxic because it's flooded. And you can see the textbook shift of blood flow away from this hypoxic region to a better ventilated region. However, if you flood the lung with endotoxin instead of saline, you see the opposite. You see that even though this lung is certainly hypoxic, that there's actually an inflow of blood flow, increased blood flow to this dependent lung region. So the lung has a mechanism for recognizing when regional hypoxia is associated with inflammation and shuts off the hypoxic pulmonary vasoconstrictor response, enhancing blood flow to resolve the inflammatory event. But then we asked, what if there's a portion of the population walking around unable to shut off hypoxic pulmonary vasoconstriction in the face of inflammation, and you smoke, or you're exposed to environmental pollutants? And so you get regional inflammation, you shut off blood flow, and now you can't resolve the inflammatory event. So the inflammatory event persists, and maybe if you're a smoker, that's the person that gets emphysema. So we recruited a set of normal smokers and non-smokers, or normal smokers, non-smokers, and smokers with early signs of centrilobular emphysema, visually detected as just little ditzels in the apex of the lung. And we showed that, in fact, the heterogeneity, or the coefficient of perfused blood flow, pulmonary blood flow, is higher, significantly higher in people in smokers with susceptible to emphysema versus smokers without any sign of emphysema and non-smokers. So you can see this increased coefficient of variation in both the non-dependent and dependent lung regions. And we reported that here. Now that first pass kinetics is a difficult study to do because because you're injecting a very sharp bolus of iodine. You can't inject it peripherally because you'll blow out the vein. So you have to feed the catheter close to the heart. Means you have extra personnel in the CT scanner facility. And dual energy CT has come out where either through KV switching or through the presence of two X-ray guns, you can capture essentially simultaneously two CT reconstructions at two different kilovoltages. And at these two different kilovoltages, the signal of iodine is appreciably shifted, whereas the normal body tissues are not shifted. So you then can use that to pull out just the iodine. And we've shown in this study in radiology that true perfusion, that first pass kinetics that I showed you, and this perfused blood volume, which is just the amount of iodine in the blood, those two measurements are very similar when we intervene and say change regional blood flow by floating a Swan-Ganz catheter out into the lung, pulling it back, blocking out more and more of the blood flow to one lung. We think that the perfused blood volume is equivalent to perfused blood flow because up to a point, as you increase blood flow, you dilate capillaries, you recruit new capillary beds, and so the two stay synced together. Now, one thing you want to do is do this perfused blood volume at FRC, not TLC, because up at TLC, another intervention we did to change regional blood flow was scan the pig at different lung inflations, and at high lung inflation, the non-dependent lung region, the blood flow is completely squeezed out. So if you're trying to look at distribution of blood flow, you want to do it at a lower lung volume. So we now recruited a new set of normal smokers and smokers susceptible to emphysema and looked at the heterogeneity of blood flow regionally, divided the lung into 40 by 40 by 30 voxel regions, approximately equal to the size of a pulmonary acinus in the human, and showed that if we map the histograms of the regional coefficients of variation, that there's a significant difference in the susceptible smoker versus the not susceptible smoker histograms. There's this shift, so you have greater coefficient of variation of blood flow, as we saw in the previous study. But then we gave sildenafil, which is known to be a pulmonary vasodilator. It's also known as Viagra, but the original purpose for sildenafil was as a pulmonary antihypertensive agent. And we showed that those people with increased heterogeneity of blood flow pre-sildenafil are converted to looking like a not susceptible subject post-sildenafil. Now, with dose decrease, the ability to get the same quantitatively accurate measurements from decreasing doses of CT exposure with the Seaman somatome force. In the original spiromics baseline study, we exposed people to approximately 3.2 millisieverts of radiation. We now can come down to quantitatively accurate images with 0.44 millisieverts, which is about equal to a couple of chest films. And here's the example of the airway tree pulled out now with a 0.4 millisievert exposure. So that allowed us to design a study looking at smoking cessation and following subjects with these detailed measurements at baseline, 30, 60, and 90 days. And the total of these exposures, including blood flow and non-contrast images, the total exposure is less than what we used to give for one baseline study. So we've looked at smokers on placebo or sildenafil and try to get them to stop smoking over time. And we then look at the lung density at TLC or RV as an index of loss of inflammation. And you see that if you continue smoking, you keep a stable baseline of lung density. If you stop smoking on placebo, you keep a stable baseline of lung density. But if you stop smoking with sildenafil, you regularly lose lung density over the 90 days, which we think is a loss of regional lung inflammation. Now, our hope was, this is very preliminary data, and we didn't have enough data to show sildenafil treated people that kept smoking, but our hope was that even if you kept smoking with sildenafil, you'd lose lung density, but in the early few cases we have, that wasn't the case, that the only time you significantly lose the lung density, losing the inflammation, if you both stop smoking and do it on sildenafil. So to get now piece together ventilation and perfusion, the xenon ventilation in CT is a difficult study to do because the people breathing the xenon gas get very loopy and they quit following instructions when they're in the CT scanner. So for the ventilation side, we take a non-contrast total lung capacity scan, and then we scan for perfused blood volume at functional residual capacity. And because to measure perfused blood volume, we measure the amount of iodine there, we can then create a virtual non-contrast FRC scan, and we do the image matching between TLC and FRC to get regional ventilation, and then that's automatically aligned with the perfused blood volume scan, which then gives us, we can do maps of regional VQ ratios, which, as the textbooks tell us, is just the match of VQ is just slightly below a one-to-one relationship. And then we can map out, call everything below 0.8 to be low VQ, everything above 1.2 to be high VQ, and we can map out the percent of the whole lung or the percent of individual lobes as in terms of high, low, or normal VQ relationships. And we can then also, lobe by lobe, map out the percent of the total perfusion or the total ventilation that goes to each lobe. So if you're looking to remove a lobe because of lung cancer, if this is where that lung cancer was, you may want to think twice about removing that lobe as opposed to treating it with radiation, because that's the major site of gas exchange. Whereas if this was the lobe, you wouldn't worry about pulling that lobe out. And then just to finish this talk, bringing it a little closer to the topic of today, we just came back about a month or two ago from doing a study in India, a little pilot study of women that cook indoors with solid biofuels and poor ventilation as compared to women that are cooking indoors with LPG stoves. And we happen right around the corner from this village find a CT facility with 128 slice multi-detector CT scan and pulmonary function laboratory. So we recruited about 34 subjects, and some of them with LP gas, some of them cooking indoors with solid biofuels, right near in Tamil Nadu in the city of Tanjavur. And here's an example. These are, again, not definitive. These are just examples pulled out because we're still analyzing the data. But here's the airway tree of a woman that cooked on solid biofuels, and here's the airway tree of a woman that cooked on LP gas. And the woman that cooked on solid biofuels had much thinner airways, that at about the third generation they thinned out to be just thread-like. And here's a way that we can take the airway tree, warp the lung so that the airway tree becomes flat on the image, and then just bring the local parenchyma along with the airway tree. And here you can see these thread-like airways in the solid biofuel subject versus these thicker airways in thicker lumens in the LP gas subject. And that trying to measure visually, we could see that a bunch of these women had considerable air trapping, but when we went to measure the air trapping by the typical methods and by the PRM method, we got no air trapping. And this picture, if you just concentrate on the high lung density in a LP gas subject and the high density in a patient with cooking with solid biomasses, the density of the lung is uniformly enhanced with the biomass cooking, and that so we think there's a uniform inflammation that offsets the threshold that you would need to use in order to identify air trapping. So using the PRM simple threshold measure of air trapping versus the DPM disease probability map based on Hounsfield unit changes regionally, Jacobian changes, etc., you can see that while the PRM didn't find any significant difference in air trapping, this DPM method finds very significant difference. And I think that this sort of thing would be important also in the things being discussed here yesterday and today. And then
Dr. Hoffman, we're going to need you to finish up for us.
Two more slides. The polarized gas, xenon, you can retune the magnet to listen to this polarized xenon, and the xenon gives different signals in gas, in the parenchyma, and in the red blood cell, so you can actually watch the transfer of gas out in the lung periphery. And then a 4D flow method, you can follow the flow patterns out into the lung from the right heart, and when you have increased pulmonary vascular resistance, you see a disruption of those flow patterns. So those are, we think, a couple of exciting MR techniques. Thanks.
So we're running a bit late. We've got time for maybe one or two questions. So let me ask you, the patient with shortness of breath and no abnormality on standard imaging, CT imaging, and normal pulmonary function tests, do you see in the technology you've been talking about an opportunity to see some change in the imaging that would suggest an abnormality or disease?
To me, it seems it almost has to be a certainty that if there's, unless it's all brain function that's causing the shortness of breath, that there has to be something in ventilation, perfusion, local inflammation, airway structure.
No, I understand that there has to be. The question is, can you detect it?
Well, in these women with solid biofuels, we do. These smokers that had completely normal pulmonary function tests, we detected this abnormality in perfused blood volume heterogeneity. I think if you do the right test, you know, people will lots of times say, well, CT didn't show anything. Well, CT just didn't show anything because you didn't look at it correctly. That you have to design the test properly, and it's pretty unlikely that these subtle changes will show up in the way a CT scan is just done typically clinically, even at the University of Iowa. You have to follow a distinct protocol, coach the people to TLC or RV. For perfused blood volume, you need these dual energy scanners. But I would think that the VA system would be ideal to set up some consistency of how you image these patients and setting up training of how you, the technicians do the scanning, and would have been terrific if you could do a pre and post deployment of with quality controlled CT scans. But you know, there also deep learning techniques are coming about, and if you can just gather the CT images, even if they aren't well controlled, it would be very interesting to use deep learning with large, massive numbers of CT scans of people that are symptomatic and people that are asymptomatic to see if the deep learning methods can pull out something that's different.
Barry, did you have a question?
Yeah, I
Yeah.
Have the issues of not being at TLC and not being at RV sort of been resolved because of the relationships, obviously, to lung density and also airway dimension measures, and those being sort of effort-dependent issues
Right.
on doing CT? Have those been solved? Can you account for those differences?
Well, you can start to account for them somewhat by doing large numbers of subjects, so it sort of washes out a little bit. But with all this fancy stuff, I've had probably 4 different students with PhD theses in biomedical engineering on how to get somebody to get to total lung capacity and residual volume, and it's pretty hard to come up with an exact method. Right now, we're looking into a CPAP machine where you get a person to a standardized airway pressure rather than a coached lung volume, but that is sort of the Achilles heel. But in studies like spiromics, where we image a person at baseline and just 1 year later, you wouldn't expect total lung capacity or residual volume to appreciably change over just that 1 year. So we looked at people with all this coaching and everything, how many people are more than 10% away of their baseline at 1 year. And with all this coaching and so forth, we lost about 5% that weren't within 10% of the volumes at the 2 scans. Whereas in COPD gene, when they apply that over a 5-year period, they lose something like, they go from 10,000 subjects to 800.
Thank you. Very interesting work.